Well, thank you so much for coming and being here with us today.
It's my pleasure.
Do you just want to give name, background, and what you do?
Well, I'm Ben Middleton, and I'm the regional CEO. I work for Centerstone, which is a behavioral health organization, and we try to do our best to serve people in need with mental health disorders or substance use disorder treatment needs.
Mm-hmm. Yeah, tell me a little more about Centerstone. How is it structured? How many patients do you guys serve? How many providers do you have?
Oh, my. Well, we have many. We're actually 4 states, to be exact. We're here in Tennessee, Indiana, Florida, and Illinois. We serve, and just in Tennessee alone, over 60,000 individuals each year, probably 174,000 across all of our what we call state business units. We offer everything from mental health outpatient to we work with individuals who have substance use disorder needs. We have an inpatient hospital in Florida. We have residential programs, group homes. So we cross the gamut, everything from early childhood to however long good Lord allow you to live. We are here to serve individuals, whatever those needs might be.
Absolutely. And you recently stepped into your role, which is overseeing Centerstone's largest division. How's that going?
It's going well. The good news is I had a transition from chief operating officer to CEO. So it was not a huge leap, but it is very different. In terms of a chief operating officer, obviously I had more internal responsibilities. I like to think of it as inward facing and leading operations, budgeting, that kind of thing. And as a CEO, obviously I'm aware of those things, but it's really more meeting the public, looking at new opportunities for growth, and just really dealing with the political climate, making sure people really understand what we're about as an organization.
Mm-hmm. And something that I've always, I guess, really admired about Centerstone is whenever I write about, executives that work there, it seems like you've all been there for so long, and which is so rare, I think. And I know you've been at Centerstone since like 1985. That must be like a really, really good work climate, I think.
It is a good work climate. Now, I have to be very transparent. I left for 12 months. So I consider myself a boomerang employee. But that was early on. I left in probably 1990, I guess it was. I came in 85, left in 1990. So I've got moving quickly to 40 years real fast. But that is the good news about this organization is we do have a lot of longevity with leadership. And we're bringing in new leaders as well. But it really speaks to the environment and the organization that we work for. And that is we feel so comfortable and really driven by the mission and what we're trying to do. As you may know, we deliver care that changes people's lives. And over the years, I've seen that mission change a bit. But we have our values that are steeped into that or really based that, and that is to make sure that we are an organization of integrity, expertise, empowerment. We are trying to make sure that people understand that we are here, and here's our core values, and we're here to make sure they get all of the access to services that they need. So I'm appreciative of being a part of an organization that long that really speaks to that, the heart of that.
Yeah, and it's probably looked a lot different in the past year and a half, especially with your roles as, COO and then going into CEO, just all the changes that have happened throughout the pandemic, which leads us to what we're talking about today with telehealth. Tell me how you guys, managed telehealth through the pandemic.
Wow. Like everybody else, what a challenge. But everything that we've ever done as an organization is always about where's the opportunity. Now, obviously, the tragic aspect of a pandemic is the hundreds of thousands of lives that have been lost through this, and the what's happened to our not only just our immediate community, but across the world. When you think about trauma and what trauma means, whether you're talking about your local community or in your state or in the U.S. or whatever, we've been traumatized when you think about the impact of what the pandemic has done. And then the good news, though, how quickly we were able to come up with a vaccine that helped us to get more stabilized, if you will, after we had this shutdown of literally the world. Yeah. We got back on our feet, and that speaks to the nature of when we hear this term, we're all in it together and coming together. When you think about how quickly this was done in terms of the vaccine, it really makes me proud to be part of just the kind of world that we live in, where collective brain trusts across the world coming together and to do something that's going to help mankind. Now, specific to our behavioral health care system, this is something we had to adapt to very quickly. We moved all of our staff across all of our state business units home within a week. Now, if you had told me that were possible before it actually happened, I'd have told you that was not possible, and it would take us months for that to happen. Well, that didn't happen. Kudos to not just our leadership in terms of making the decision, but kudos to our IT team and all of our departments and all of our staff who decided, we're going to make this work, and they did it. And we were home within a week, providing services to our patients, clients, however you like to refer to them, in their homes.
Yeah.
And we were doing the service from our staff's homes. So that is just a humongous feat. Now, that, believe it or not, was the easy part. We thought that would be a challenge. But over time, as things changed, and that's the good news, is we got back to some sense of normalcy. People got to, we realized that everybody couldn't be seen in a virtual fashion. And so we had to, obviously, it was always our intent to bring our staff back into the clinics, to do community services, back in people's homes. But how would that look? What we knew was it wasn't going to look the way it was before. So I'll use the word, and you've probably heard it over and over, hybrid, right?
Yeah.
We've got to make sure that the people who need to be seen face-to-face are seen face-to-face. The balance of that is you got to make sure that the provider, whether they're a clinician or they're in support staff, whatever, are comfortable doing virtual care. Yeah. So there was just this huge, talk about the impact of the pandemic and how do we retool, how do we regroup, how do we deliver these services that are so needed in a different format. So it really is, Carrie, at the end of the day, we're doing it face-to-face as before, and we're doing it virtually. But even with face-to-face, now we've got to make sure we can deliver that care safely. So it isn't just people walking into your clinics. We got to make sure, as you probably experience when you go into a place, we got to take your temperature. You got to wear a mask. You got to keep the 6 feet, between. I mean, it is really different after, and I don't say after the pandemic because we're still in that, but we're seeing things improve. But it's really a different way in which we deliver care, and that has been a huge adjustment for us and our staff.
Yeah, absolutely. And I guess backing up to March 2020, when all of this change is going on, and you have to take these services virtual, and you took your entire staff, to working at home. How did you guys do that? And what technology did you use, and how did you scale it for the entire business?
Well, I'll tell you, I can tell you how do we do it. I couldn't tell you. And I'll just be very candid. I couldn't tell you. But our IT team, I can tell you the equipment aspect of it. I mean, obviously we had to, move desktops and laptops. And the good news is 50% of what we do is, in fact, maybe more than that, 60% of what we do is community-based. So we've always had access to laptops. All of our staff get equipped with laptops and cell phones. So that wasn't a huge leap. But many of our support staff, front desk operations, call center, are used to working in a centralized facility. And they, in turn, we had to do a little bit more work in terms of moving equipment needs and that kind of thing. But that transition happened so fast. Now, obviously, it wasn't perfect. We hear about the 80-20 rule, get it 80% right. We were probably 60-40, but nonetheless, we got it done, and people were able to do the work that they needed to do, whether they answered phones in terms of our call center, our front desk operations, scheduling clients, seeing those clients, doing the documentation, all of that. Just keep in mind, folk are doing that from their homes.
Yeah. And were you conducting, I guess, client calls via Zoom, or what do you use to connect with them?
The platform we're using currently is Zoom. Now, we've tried other platforms. We did the MD platform. We tried, experimented with some other technology. Really, it all basically got to Zoom is the best for now. Part of where we're trying to go is trying to integrate our platform with our EHR, electronic health record. And that's really the biggest issue. You've got a separate platform in which you're providing the care, but you're documenting in an electronic health record system that's not connected, and they don't talk. So ultimately, we're going to be moving to having those two things together so that it's not requiring you to have two screens open. You have one screen and you're doing your documentation. That's really where we want to go. And that technology is not far off. It's just not for what we are doing. It's not here.
Yeah, I was curious if Zoom like had a function where you could integrate it, or if it's really just, what everyone uses right now for conference calls.
I'll tell you, I don't know what everyone's using, but I'll tell you, a lot of folk are using Zoom right now.
That's interesting.
And I think that's where I'll step out of that's not my lane.
Yeah.
But I will tell you that there's going to be a lot of discussions. As you well know, people seize opportunities. And I think those folk who are engaged in technology and have these platforms are going to have lots of discussions with individuals who are providing care to see how we can integrate those. Because there's an opportunity there, from a sales standpoint and from a need standpoint.
Yeah. I think that the entire spectrum of how we can provide telehealth services is really interesting. It can be as simple as just a phone call to this technology that allows you to run diagnostics or screenings and, wearables. And it just it's such a huge spectrum right now and it can go either way.
And I will say this, integrated care, and I say integrated care is actually telehealth, integrating telephone and video is not foreign to us. We've been doing it for over 20 years.
Yeah.
But when we were doing it, stepping off, putting our feet in the water, it's been about 4% of our business.
Yeah.
Now we're looking at about 40% of our business.
Yeah.
And that's huge. And to make that leap in less than a year.
Yeah. And I remember early in 2020 when you first got it started, you said it was 70% of
It was 70% there because we were doing primarily telehealth services. Excuse me. We were also doing telephone. So many of our clients have been familiar with getting telephone contacts, and we do that for our community base. Our bachelor's level staff are doing linking and referring, calling, checking up on clients, that kind of thing. When we're delivering care, however, in terms of clinical services, that has always been done with telephone or audio and visual. That's the best way to say that.
Yeah.
And so there's a majority of, or some of what we do is telephone only, which is designed for that. But in terms of delivering clinical services like therapy, med management, those kind of things, our primary way of doing that is televideo.
Televideo. And you've had this, like you said, for at least a decade, but it seems more like smaller scale, maybe pilot programs.
Right.
What really facilitated you to open up? I mean, I know we had the pandemic and the emergency period, but I know we've discussed before, regulations were dropped, reimbursement was brought in. How did that really help you scale this the way you needed to?
It's, again, nobody knows, right? As a provider, we don't know. And the people who, as you were talking about, the people who pay the bills don't know. It's not a foreign concept. This has been in play for many, many years in terms of televideo. But with the capacity and the mass that we're talking about, that was a shift. The good news for many of our states was they relaxed through executive order the rules. We have always been able to deliver telehealth services here in Tennessee with our managed care organizations, right? That has not been true of all of our state business units. That was not necessarily true in Florida. Certainly wasn't true in Indiana or true in Illinois. Now, or at least during the beginning of the pandemic, folk relaxed those rules and through executive order allowed us to still deliver care without changing in rates, no decrease in rates, and allow us to do telephone only or televideo. And obviously, in their wisdom, and we obviously applaud them and appreciate that, not doing that would have meant hundreds of thousands of people wouldn't have gotten care.
Right.
And not just for Centerstone. I mean, period.
Right.
So that got relaxed. Now, as we got further into it, and those executive orders were time-based, some were 6 months. Ours, for Tennessee, actually changed. It became law, where we are no longer under executive order, but we are allowed to continue to do televideo, no change in rates, with the ability to use telephone only if the person or the client that we're trying to serve doesn't have the capability, doesn't have the equipment. So it's a good position for us to be in Tennessee. That's not true in Indiana, right?
Yeah.
They can't deliver. They can't use telehealth services. So in our different state business units, things change. But it doesn't just impact Centerstone. It impacts any provider, at least specific to behavioral health services. No matter what state you're talking about, you got to look at what the state requirements are, state rules are, policies, regulations, that kind of thing. We're very fortunate here in Tennessee to be in a state where the regulations, quite frankly, support our ability and continuation of telehealth services.
Well, that's fantastic. And I guess for the past year, when we didn't have those regulations and everything was kind of like wiped clean and you were able to deploy it, what did we learn? Where is telehealth best used in behavioral health, mental health space?
Well, that's a many-pronged question, quite frankly. It first starts with what's the patient experience? And again, our research institute has been able to gather the data. And of course, it's only on the individuals who actually complete the information. But at the end of every session, Zoom session, they have an opportunity to give us feedback. What was it like? What was your experience? Challenges, that kind of thing, and basic questions. And what we've learned from that is our patients love it, right? So that's one part of that prong. The other part is, what was the provider's experience? How did they feel delivering that service? Do they feel like they delivered the best care? Was it beneficial from the standpoint of could they do the work or accomplish the task, whatever those treatment goals are or what have you, via the telehealth session? And that has been met with a resounding positive. Now, are there providers who are uncomfortable, who you'll hear things like, I didn't go to school for this. This is not my comfort level, seeing patients through a camera. Yes. And they're not the best individuals to do that, use that tool. And here's the good news. We're not going to force them. We need a willing provider, one who's comfortable, and many of them are, and we need the willing patient. The good news is on both sides, we're seeing many willing providers and many willing patients. Now, it starts there. Then the next piece of that is, but is it appropriate? You may be willing to deliver service, and you may be willing to receive the service in that fashion, but is it appropriate based on your particular need? And there's where our research institute is helping us. They're gathering that information. They're looking at, okay, so what are the outcomes that we're seeing? We compare those outcomes to what it's been like seeing them face to face, and how are they doing in terms of meeting their treatment plan or meeting their treatment goals in a Zoom session. So far, we're seeing very good success with folks who present with depression, anxiety disorders, that kind of thing. And in some cases, providing them services for substance use disorder. Jury's still out on a lot of those things, other things. And what I mean by that is I think it's way too soon to say it doesn't work, it does work. We just want to say what's the trend right now? What are we seeing? And as long as we're not seeing any lack of improvement, equal to, and maybe better than, and the better than comes from engagement. The more you can engage that patient or that client, the better the outcomes are going to be. That's what telehealth has enabled us to do.
Yeah. Let's unpack that. You talked about the Research Institute, and I have some of the data that you guys gave me, and it said that 75% of your patients that use telehealth said they liked it, and 66% said they would use it in the future. I mean, that's just insane. And then for advocacy ratings, whether it's as effective as in person, for I guess the illnesses that you talked about, it said that some may even be more effective with telehealth. I mean, how is that? What changes about that?
I'm gonna say here that probably it's going to have to do with engagement.
Yeah.
I think it's a big contributor. Now, I want you to think about that. If you are going for behavioral health services and you've got to make the appointment, you got to get in your vehicle or some form of transportation, you got to get there. And even before, and while you're going through that, you're processing in your head for the first time, if this is the first time for you, it's like, gosh, I'm going to a mental health center. What is that like?
Yeah.
And we can't remove the whole notion of stigma.
Yeah.
Why can't I get this together? Why can't I control myself? Whatever those things are, the messages that are going on in your brain. You eliminate all that. I no longer have to worry about how am I going to get there. I actually can set up an appointment, make that call, set that appointment up, and see them from the comfort of my home or wherever I happen to be on that particular day. Nobody's going to know I'm having this session except the person I'm talking to. Now, I want to be real careful here because I don't want to give the impression that stigma is no longer an issue, because it is an issue. I'd like to think that we've made some significant headway and we're doing better, as evidenced by the payers, as evidenced by people seeking care and all of that, the education. But it's still real. And what a way to eliminate barriers like transportation or stigma when you can get a chance to use telehealth or televideo.
Yeah.
That's a way to deal with it. Now, it is not the answer because we still have, and I've said this so many times, I'll go to my grave fighting to make sure that we remove that stigma. It's not fair. Behavioral health care is health care. No one should feel ashamed to go seek help. No one should feel that they're less than because they're seeking help with whatever they're wrestling with. And we get to the point where getting mental health treatment is like getting a cast on your leg, then I think we're there. We're not there yet, but I think that's the evidence for me.
Yeah, getting more accessible. And I guess the data points that would prove that for you guys is, you know, the number of new clients that you retain and the number of appointments that are kept. Like, are you seeing increases in those areas? Are people keeping their like telehealth appointments more so than they would their in-person? Are you seeing more people come back after they have been introduced to this?
Absolutely. And that's part of the engagement.
Yeah.
Removing the barriers and then seeing people more apt to keep their appointments is, I mean, you've got to, the literature says that if we don't connect with that after the first admission, when you do all the intake and processing, and if you do not have that person coming back within at least the next week or within 2 weeks, they're probably not going to come back.
Yeah.
You've missed that opportunity. Well, much easier to do when they're feeling like I can do that through telehealth.
Yeah.
All I got to do is call you up, you know. I'm more apt to keep that appointment when I've removed those barriers. What does that do for treatment? Better engagement, better outcomes. Poor engagement, poor outcomes. So it's not just the treatment model that you're using. It's not just the evidence-based practice that you're using for a particular disorder like depression. It is really that and the client feeling like I'm benefiting. I'm getting something out of this. And they keep coming back. They may feel a little iffy the first time, feel a little more comfortable the second time, feel like, you know, this might help me. I'm actually using it. So that's where the difference maker is. And I think that's what telehealth has done in terms of increasing client engagement and having that need in terms of what we're doing grow. We've delivered 1.9 million in services since March of 2020, and that's mid-March. And the fact of the matter is that's about 35% of all our services.
Yeah.
That's huge.
Wow. Yeah, that's massive. Yeah. And you talked about the physician experience during this, and I imagine that, you know, with mental and behavioral health, you might have to train your physicians a different way to provide that same care over virtual. What are those considerations that you have to take in?
Oh, my. Well, first of all, you know, when you're doing what we call psych evaluations, that is much easier and I think more effective face-to-face. Not impossible to do at Zoom, or do at telehealth, but it is more effective that way. So that first treatment, or that first encounter, if you will, not treatment, but that psychological or psych eval, we have people come in, okay? The physician has to be able to see that person, you know, experience that like we're talking right now. You can't beat that. I mean, there's something about this space that we're in now. But you can do that via telehealth. Quite frankly, we've heard some of our practitioners say things like, you know, I can really zoom in on the patient and they don't even know I'm doing it. You know, so I can look at their eyes, look at their, you know, their gestures, that kind of thing. So again, I would say that that's where we start. Bring them in face to face. But it is not a mandate that we do so if there's no way or there's no easy way for them to get there. We want that, though, in terms of physician services, we want that to happen. And quite frankly, our med providers or our physicians want that to happen as well. We call them psychiatrists. But yeah, they want that to help in the well. We use nurse practitioners as well. And that's their preference. Now, after that first session and you do the psych eval, they can determine whether or not it's appropriate for them to continue or to start telehealth.
Yeah.
Don't know. But they can determine that.
Yeah. An interesting thing that I've heard from clinicians that are using telehealth for their patients is that they get to see a different view of how their patients live. Like they have their patients when they're on the telehealth call, take them around the house and like, show them, like give them a house tour, show them what's in the refrigerator. So you almost get to see the social determinants of health and how that person's living and their environment and how that might be affecting them, which is just is an amazing thing that I never even thought of. It's so simple, but it's got to make a huge difference.
It's a great point, Kara. Our community-based staff, our bachelor's level staff, who actually, it's their job to go into the homes. And we don't take that lightly. I mean, I want you to think about it. That is the most sacred place.
Yeah.
Is your personal space. That's the one place that your doctor doesn't go to, your clinicians they don't go.
Yeah.
So to be invited into someone's home to say it's okay for you to come and see me in my home, that's a big deal. And we don't take that lightly. We don't go there to judge. We don't go there to see what's wrong. We go because we can work with them best in their natural environment. And our staff, our case managers go in there, they do linking and referring. As you said, social determinants of health. What else do they need? I mean, at the end of the day, all the treatment that we do is fine. But when people are hungry, don't have a place to sleep, don't have an environment, a roof over their heads, that impacts treatment, right? That's a barrier to services. So going in there, seeing what those other needs are, as you said, social determinants of health, that actually impact the success of persons getting care and how effective that care is going to be, going hand in hand with that that's huge. So we, on purpose, find the opportunity to engage that client in their home, even helping them out with things like filling out a job application. Okay, you got a barrier to transportation? Let us help you figure that one out. You didn't get a chance to see your primary care physician? You need transportation? Maybe we need to help you get there. If it's a bus or it's an Uber or whatever it is, or maybe it's TennCare transportation. The idea is we can help them best in their natural environment. So you spoke to a psychiatrist being able to see what's going on in their home. Seeing that cue, it might give the opportunity for that psychiatrist to say, who's the case manager for this patient? I want to talk to them about something I observed.
Yeah.
Right? That's what a team-based approach to delivering care.
Yeah.
Didn't have that opportunity before.
Right.
When I was a clinician years ago, people would come in and I'd see them, and all I saw was them on at their best behavior. It's like you go to see a primary care physician, the day you got to go, it's like, oh, I don't want to go. And you're like, I feel better today.
Go to the dentist, brush my teeth, flossing for the first time
You're
in a
on
year.
your best behavior. Well, it's not different with a behavioral health care.
Yeah.
They're not as good as they think they are, but they're on their best behavior.
Yeah.
So if what you're seeing is any way disturbing, understand they're giving their best at that moment. Well, people relax when they're at home. And you really get a chance to see what they're reckoning with and what they're dealing with. And so that's how that's helpful in treatment.
Yeah.
And that's what telehealth has allowed us to do is do better engagement that way.
Yeah, absolutely. Well, let's talk about demand too, because it seems like there's always been, this huge demand for behavioral mental health and not enough clinicians to fill it. And as you said, like a stigma that sort of stops people from seeking help in the first place. But also with the pandemic, like people need help, like how to cope with this. How do we get through all of this tragedy? And I just can't help but wonder, how are you guys prepping for that huge surge in demand that you're expecting, and how will telehealth play a role in meeting it?
Well, before I answer that question, let me start with we have always had challenges meeting the need in terms of workforce, but never what we've experienced right now.
Yeah.
Never what we're going through right now. We've always had, we've always had the opportunity to hire, and then the other piece of that is hire and retain. We've always been competing for those resources of nurse practitioners, psychiatrists, therapists, you name it. Kara, I got to tell you, I've never seen anything like this before, and I've been doing this for a long time. This is a workforce shortage that not only impacts what we do, speaking to, how we're going to deal with that surge or that demand, but it's impacting, I'm just going to speak with U.S. There's not a place I can go and not see there's a hiring need, right?
Yeah.
So we've got to get more creative. We as in Centerstone have got to get more creative about getting out there and speaking to individuals for future need. But while we're trying to deal with the future need, going to colleges and universities and educating, we've always done internships and provide training. That's our obligation as an organization. But we've also got to, while we're doing that, deal with the immediate need. And all transparency, we are hurting.
Yeah.
We are hurting at all levels. Bachelor's level staff, master's, non-licensed, licensed staff, getting down to supports, our support services, front desk operations, business operations. It's throughout our whole operating system. And it's really getting us to really launch into initiatives that, quite frankly, I never thought we'd be doing. But, and I say doing, at least at the level at which we're doing them. We always do them. We're always out there recruiting and looking to tell the Centerstone story and let folk know it's a great place to work. But then everybody else is doing the same thing. And you've got people leaving the field. You got nurses leaving the nursing field. Yeah. This pandemic has changed their minds. I know we hear a lot about the hospitals, and I think they're being impacted most significantly. But nursing, LPNs, RNs have, it's a market right now.
Yeah.
And it's in their favor. Not mad at them. That's just a reality.
Yeah.
But we got people leaving the field who says, I can't do this, right? When I said trauma, this is what I'm talking about. All of us have been traumatized, to one degree or another in this whole situation. So from a workforce issue, that's the factor that we're most concerned about, because while we're seeing this surge for treatment or treatment needs, we don't have the capacity. And that's the challenge. We don't have the workforce that we need in place. And when I say we, I'm talking beyond Centerstone.
Yeah.
I'm talking about in behavioral health care, physical health care. We've got some issues that are going to be impacted for years. We got to get people back in this business, back in this field, and know that it's good work, it's rewarding work. But there are folk who are leaving it, and they're leaving in masses. You probably heard the term the Great Resignation. Yeah. You got folk who are just, and if you believe the literature, they're saying 60%. That's huge. Now, I hope that is wrong.
Fingers crossed.
I hope that is wrong. But I'll tell you what, it's going to be some pretty significant percentage. I don't know if that's 20, 30, but there's going to be a significant number of people who are going to leave the field of behavioral health services or leave the field of health care. I'm talking about direct care. And that's going to have an impact on our ability to meet the demand. And then it's competing for those same resources. So people didn't jump into social services because they wanted to get paid well. That wasn't they're altruistic. They want to do good. They want to help people and get at least some reasonable wage for doing so. Well, we've got to figure out a way to compensate those folk better than we've done before. Yeah. And that doesn't necessarily translate into you'll get people to come to the table. But the only way to get people to come to the table is you start there. And then you're able to tell them the story about why it's good. The mission that you're on and the mission you want them to be a part of is something that's going to be good.
Well, and I'm curious because for the past year, I've seen telehealth be applied to sort of optimize, our workforce and optimize the capacity that they have, especially, like you said, in hospitals where they were really having constraints on their bed space and the physicians and specialties and nurses. I wonder if telehealth will help while you do try to recruit and bring on more providers. Will it help optimize the providers that you have now and their schedules and being able to serve more patients than they have been able to in the past?
My hopes is that will be the case. Speaking specifically about Centerstone, we have a virtual outpatient clinic now.
Ooh.
Yeah. So again, that's a outgrowth of the telehealth that we've been doing. And we feel like there are individuals, if we can tap into those resources and they don't have to be in a facility. Frankly, if you can get them, in terms of licensed staff, if you can get them licensed across different states, they could be anywhere. So they could be sitting in Indiana, they could be sitting in Georgia or Kentucky or wherever. They could be sitting in Los Angeles, California, right? The challenge there is getting them the licensure in each state for that to happen, and we do that. But we've got to bolster that. It's got to be more. But that will help, to your point, the issue of dealing with the need, the utilization. So then it's not necessary that you have to be living in the state that you're in order to get access to a provider. The more you widen that net, the more providers you'll have access to, and you can meet the needs of your particular state. Now, keep in mind that that's not rocket science, so everybody's going to be doing the same thing.
Yeah.
Everybody's going to be doing the same things, right?
Yeah.
You got startup companies that are looking at just doing like we're doing, virtual care. So they're hiring away from organizations like us.
Right.
Giving them huge signing bonuses and that kind of thing. Now, this is not proof. This is not proven, but I will say that I think that there's going to be a coming back. I do. I think that initial kind of offer, I'll pay you X for every unit of service you provide, and I'll pay you a $500 or $1,000 signing bonus, and come join us and all that. I think that will play out over time. And I think there will be people who will, and not that it will go away necessarily, but there'll be people who realize, I just still want to get back to seeing people face to face. I'd rather do a hybrid, and that's all I do all day. So.
Yeah, I guess that leads into my last question really well, and that there does seem to be this cautious line between effective telehealth deployment and this mass commercialization or utilization, which I think you're alluding to, in this behavioral health space. And I wonder, how do we find that proper balance while also addressing this rising demand, but also this waning workforce?
I can't speak to how we do that across globally or even in this country. I can say this, that the reality is there's going to be a lot of folk out there, a lot of organizations who will see the opportunity, and it's fair to seize this opportunity and to create virtual spaces and hire as many people as they can to meet that demand. And there'll be people who will take advantage of that, who will need that. But there are there are a number of folk who suffer with different disorders that just won't work.
Yeah.
It won't work. If you want to do some marriage counseling that way, you want to do some, anxiety stuff, depression, that kind of thing. There's a space for that. But we deal with some severely mentally ill individuals, okay? We deal with, in terms of adults, severely emotionally disturbed children. That space is not going to work for all of them. And so there's still going to be a need. There'll never be a time in my mind, as I sit here today, where we will eliminate or not have that face-to-face or need for that face-to-face option. Now, to what degree? What percent? Is it 50-50? Is it, 60% of the people can do virtual and the other 40? I don't know what that is, but there's going to be that hybrid. That's just the way it's going to be. There's certain things you just can't do. Similar to, dental work. You can't do that virtually, right?
Yeah.
Surgery. I might be able to consult with you while you're doing surgery, but somebody's going to be in that room unless they get robots that start doing stuff. And pray God we're not using robots to deal with behavioral health care. Right?
Gosh.
But yeah, there's a space. There's a space for all of it. There's an opportunity for all of it. And so I don't think you throw the baby out with the bathwater. I don't think you stop because it becomes so commercialized. There'll be a space for that, as there is in any other element of healthcare. But I do believe, from Centerstone's standpoint, we want to be in whatever space makes the difference in delivering that care, and whatever works. And we're going to make sure that we're continuing to hold ourselves to that level. If it's effective and it's working and it brings about the results, the value that patient or that individual needs, wonderful. If it doesn't, I don't care if it's virtual or face-to-face, we're not doing it.
Yeah.
Yeah.
Absolutely. Well, thank you so much for coming on. We've really appreciated your insights and having you.
Thank you for having me. It's been my pleasure.